I'm just going to introduce you to our first speaker of the nursing track. I have the honor to introduce you to one of my favorite new people that just came to University of Kansas Health System in the summertime. He has a very impressive bio. I'll just give you a few highlights. He did his undergraduate at Stanford, and then he got his MD at Harvard. He did his residency at Johns Hopkins, and then he did his fellowship at Duke, and then he was actually a faculty member there for 10 years. And he has just done a lot of work with research, and today we're going to actually hear a little bit about some of that. And he's just has such a great holistic approach and perspective on things. I think you guys will really enjoy him. He came and joined faculty at University of Kansas Cancer Center in the summer, like I said, and we are just so thrilled to have him on our team. So Tony Sung.
Thank you, Steph, for that wonderful intro and the opportunity to be here today. It's great to be here to talk about optimizing fitness for transplant and cellular therapies. I do have some disclosures listed here. The ones that I highlighted in red are ones that may be coming up, some research funding from studies from Novartis, Entrum, and Series, and some research product studies from Glossato and BlueSpark Technologies. So I'm a stem cell transplant physician, and I love transplant because it can be a cure for cancer, for patients with leukemia, lymphoma, other hematologic malignancies. But the problem is 10 to 20% of our patients may die from transplant complications. And one of the first things I learned as a fellow about stem cell transplant from my mentor, Nelson Chow, is that the better you are starting transplant, the better you do during transplant. And I think this is a simple statement that pretty much everyone in the room will agree with, but as with many simple statements, when you dig a little deeper, it raises additional questions. Specifically, what does it mean to be better? And more importantly, how can we make our patients better and thereby improve their outcomes? And so today I'll talk about our attempts to answer these two questions through what I call our POP programs, our Clinical Pre-Peri Post-Treatment Optimization Program, or CPOP, our Observational Pre-Peri Post-Treatment Optimization Program, or OPOP, and our interventional programs, or IPOPs. So I'll start with a case. MM is a 67-year-old gentleman who was seen for consideration of stem cell transplant. And like many of our patients, he asks, Doc, what are my chances, and am I going to be okay? And this is probably one of the shortest case presentations. You'll notice that I even left out his disease, because simply by looking at his age, we can know that his odds are not as great as if he was a younger patient. Patients who are older than 50 years have significantly worse overall survival, on average about 50%, compared to patients who are younger than 50 years. And so a lot of investigators who are much smarter than me came up with the idea of doing a geriatric assessment to better understand the risks of older adults. So right now, we conventionally do a pretty good job, I think, as physicians of looking at comorbidities, and our social work colleagues and our pharmacists help our patients look at social support and polypharmacy. But we don't do as good of a job looking at things like physical function or cognitive function, mental health and nutritional status, and also things like food insecurity and financial toxicity and other social determinants of health. And so we created our CPOP program to look at these things, to evaluate physical function. We ask patients to do a 6-minute walk test, a short physical performance battery, a 30-second sit-stand, and a Freed frailty assessment. For cognitive function, we do a Montreal cognitive assessment, and so on and so forth, looking at mental health, nutrition, food insecurity, financial toxicity, and other social determinants of health. And the idea is, as we identify deficits in these individuals, we can refer them to the necessary supportive services, physical therapy, occupational therapy, speech therapy, and psychology, and try to get our patients in the best shape possible, try to get them better so they can do better during their transplant. So this is data from 318 patients that were seen at new patient evaluation. So these were patients referred for stem cell transplant, were seen by a physician, and the physician said, thumbs up, you are a transplant candidate. And this is the results. So here, each row represents an individual patient. Each column is the 4 domains that I mentioned earlier: physical function, cognitive function, nutrition, and mental health. Dark blue represents an impairment in that individual, light blue represents no impairment, and white shows that the assessment was missed for whatever reason. So you can see that 75% of our patients had impairment in at least one domain, 43% in multiple domains. And again, these are patients who are already seen by a physician and the physician gave them a thumbs up as a transplant candidate. Looking at the different domains, you can see physical function is most common at 57%, followed by cognitive function and nutritional status, and then mental health. As I said, this originated out of geriatric assessment, and we certainly found a high level of impairment in older adults greater than 60 years. But when we also looked at our younger patients, 18 to 39 years and 40 to 59 years, we also saw a fair amount of impairment in those populations as well. And when I first saw this data, I was like, I don't believe this. You know, looking at the 18 to 39-year-olds, almost every single one of them had impaired physical function, and I was like, I see these patients walking into clinic. They look good to me. But then I thought about it a little bit more. You know, number one, the majority of our patients are older than 60, right? So I'm looking at my patients with a lens towards a 60-year-old, which isn't really fair to the 20-year-olds. And then second, you know, they may do fine just walking into clinic, but if you compare them to where their peers are, you know, when we compare adjusted for their age, their height, their gender, and so forth, they are significantly underperforming. And I think there's a realization, you know, there's a disconnect between clinical impairment, right? They may be, or absence of clinical impairment, they may walk in and they may be doing fine, but there can be subclinical impairment going on, and it's important for us to be sensitive of that so we can intervene earlier before it rises to the point where the patient is bedbound and can't get out of the hospital. Also, in terms of social determinants of health, we found that 13% of our patients screened positive for food insecurity. Those patients were much more likely to be malnourished and need total parenteral nutrition. They were also more likely to be depressed and struggle with financial toxicity. And in terms of financial toxicity, about 29% had mild financial toxicity, 24% moderate to high financial toxicity, and those patients were much more likely to have decreased quality of life as measured by the FACT BMT at 180 in 1 year after transplant. So going back to our first case, we saw our patient in March with our CPOP assessments. We found impairments in physical function and nutrition. We referred him to a physical therapist and a dietitian. He did PT 3 times a week at home. And by the time he was ready for his transplant, his disease was in remission after more chemotherapy in October. All his impairments had resolved. He proceeded to transplant and is doing great 6 years later. I also want to present another case. This is one of my own patients, a 65-year-old woman with AML arising out of MDS with a variety of mutations who would benefit from stem cell transplant. She was a little quiet in her exam. I thought that was just her. But then when we did her CPOP assessment, we found her MoCA score was 20 out of 30, which is on the borderline for moderate cognitive impairment. She also failed her 6-minute walk test, her short physical performance battery, and her perioperative nutrition screen. And we attempted physical therapy, occupational therapy, and had her see a dietitian, but she didn't really improve. And so we had a long conversation with her and her daughter, and we decided that in her case, a transplant probably wasn't in her best interests. If you look at survival curves for patients who are both older as well as impaired physical function, their survival is less than 20%. And instead, we decided she would probably do better without a transplant. She went on and lived 3 more years before dying from disease relapse. And I consider that a win because she's someone who we had a very good chance, 80% chance of killing her within the first year from transplant complications. And instead, she got that time with her family and better quality of life. And I think it emphasizes to us that, you don't just come in and get a transplant because we're a transplant center. We really want to look at our patients and think about what is the best outcomes, what are the best treatments for them. So in addition to those initial pre-transplant evaluations that I mentioned, we also conduct longitudinal evaluations on our patients, looking at day 30 as new complications may arise as a consequence of their treatment, day 90 as they're getting towards the end of their treatment and heading home, and then 6 months and 1 year and annually thereafter as part of our survivorship programs. So that's one sense of what it means to be better, right? CPOP is our clinical program. We're doing this as standard of care, but what else does it mean to be better? So OPOP, as I mentioned, is our observational research program. We want to try to use patient-reported outcome measures or other assessments to better understand what's going on with our patients. These things may not meet the level of evidence to be standard of care yet, but we think they're important, and by gathering this data, hopefully we will soon be using this in the future, just like we're doing 6-minute walk as standard of care. And so we want to look at patient-reported outcome measures facilitated by electronic data capture systems, things such as the impact of adverse childhood events or ACEs, things like symptoms that can be monitored using the patient-reported outcome version of the common terminology criteria for adverse events. We want to do additional assessments like cardiopulmonary exercise testing to look at cardiorespiratory fitness, ultrasound to evaluate steatosis or other complications, and body composition to better understand our patients. We also want to use mobile health to monitor our patients. I think with these new technologies, we have a great opportunity to care for our patients after we send them at home. And we have collaborations with companies like Garmin and TempTrack. And then finally, we want to use correlative studies to drive mechanistic insights and identify future opportunities for interventions. And then finally, how do we make patients better? So this is where our interventional programs come in. So one example I want to give is a study on food insecurity that builds off our work already with food insecurity and CPOP that I showed you earlier. Based on the finding of the prevalence of food insecurity in our patients, the association with complications like increased malnutrition, need for total parenteral nutrition, increased costs, we are now leading a multi-center randomized clinical trial with Duke, Stanford, and Memorial Sloan Kettering, which consists of healthcare community partnerships with food banks to directly deliver food to patients in clinic. And I'm joined in this with my co-PI, Anna Arthur, in the Departments of Dietetics and Nutrition Sciences. And the idea is that when patients come into clinic, we just give them food. We give them 2 bags of food with about 2 to 3 days worth for one individual. And we are partnering with Harvesters, our local food bank here in Kansas City, to deliver that food to the patient directly to save them some of the additional effort and trouble of having to go there, the stigma of signing up for a food bank. And plus, if you think about it, 3/4 of our patients live more than an hour away. So they don't even have that social support. So we can help provide that social support and that bridge for those individuals. We've standardized the nutritional content of the food bags. So, a patient may get canned collard greens in North Carolina and canned kale in the Bay Area, but we're still delivering the same nutritional intervention to our patients. Another example of an interventional study is our remotely monitored mobile health supported high intensity interval training intervention. This is based on work done in OPOP looking at cardiorespiratory fitness. We found that transplant patients with low cardiorespiratory fitness going into transplant have significantly increased mortality. They have also spent significantly more time in the hospital. So we came up with this idea to have a high-intensity interval training exercise program to prehabilitate our patients and improve their cardiorespiratory fitness. We chose high-intensity interval training because we can see improvement in as little as 4 to 8 weeks, coinciding with the pre-transplant period, when we're working up our patients, trying to find them a donor and so forth. They can improve with as little as 90 minutes of exercise a week as compared to 180 minutes with the standard US guidelines. And it's personalized to baseline fitness. So when my colleague David Bartlett first suggested doing high-intensity interval training, I told him, David, you're crazy. I see 70-year-olds with cancer, they're getting chemotherapy, they can't do high-intensity interval training. And his point was, Tony, high-intensity interval training is personalized. What's high intensity for them is going to be very different from what's high intensity for you. And so we said, okay, we'll give it a shot. The program, we did this back when I was at Duke, was to do 1 session in person, but then as mentioned earlier, 3/4 of our patients live more than an hour away. They can't come back 3 times a week with a conventional exercise program. So instead, everything else was done at home, and we supported it with our mobile health program, and we enrolled allotransplant patients who will go to transplant between 1 to 6 months. This is what the data looks like. So it's a 30-minute exercise session, a 5-minute warm-up, 20 minutes of intervals. So you can see the heart rate on the y-axis, the time on the x-axis, and then a 5-minute cool down. They conducted 10 intervals over the course of the exercise session. The high-intensity intervals were targeted to 80 to 90% of their heart rate reserve, so personalized for the individual. The low-intensity intervals at 50 to 60% heart rate reserve. The type of exercise was home-based, whatever the patient wanted to do. As I said, for a 70-year-old, simply a brisk walk may be enough to get them into that high-intensity heart rate intervals. They were to do it 3 times a week, and we basically did it from when we enrolled them to when they went to transplant. And so this top figure is from a fairly fit patient, and week 1, week 4, they continue to do well with their exercise program. The bottom figure is from an unfit patient, so you can see their heart rate targets were much lower than that fit patient, and as often happens with patients who are less fit, they overexerted themselves, and then they tired out, and they stopped exercising halfway through. But unlike many exercise programs where a patient can get discouraged and stop, because we're able to download that data same day, we can call the patient and follow up and then support them. Yes, we appreciate you exercising, good job getting started. I saw that you tired yourself out, and you actually slow it down, right? Pay attention to your heart rate. We give you an Apple Watch or a Garmin when you're exercising. Pay attention to that. And so by the time week 4 came around, the patient was exercising the full 30 minutes. It wasn't quite the beautiful intervals of that fit patient, but certainly I think they were benefiting, and most importantly, they stayed engaged. And when we looked at the results, every single patient in our study had an improvement in their cardiorespiratory fitness. On average, it was a 23% improvement. And if you look at cardiorespiratory fitness, studies show that you lose about 10% per decade of life. So a 23% improvement is a huge gain. There was also an improvement in 30-second sit-to-stand repetitions, although with a small sample size, it wasn't statistically significant, and similarly, a trend towards improvement in 6-minute walk distance. So how else can we make patients better? One concept that we're really focused on is the idea of resilience, which is defined as a dynamic property which enables cells, organs, organisms, or individuals to resist or recover from the effects of a physiological or pathological stressor, such as going through a transplant. Oops, sorry, that got messed up there. That was supposed to focus on individuals. And so this brings to my third case. RW was a 67-year-old woman with high-risk myelodysplastic syndrome. She underwent a transplant with busulfan fludarabine conditioning, and she enrolled in one of our clinical trials of pasireotide, which we hoped would prevent graft-versus-host disease. Unfortunately, the study did not work. She developed GI-GVHD, and after steroids didn't work, she decided to enter hospice. And this was a really tough case. As many of you know, we have half a dozen different other interventions for graft-versus-host disease. We tried to talk to her about these things, but she was just done. She didn't want any further interventions. She just decided that hospice was for her, so we respected those wishes. But I'll always remember, I was visiting her and her husband at Hawk, which was the hospice facility. And afterwards, I was talking with her husband when he was getting coffee, and he said, I shouldn't have pushed her into it. She wasn't ready. And those words really hit me because as her physician, I thought about this, that applied to me as well. I probably should not have pushed her into it. She could have benefited from a transplant. She was enrolled in a clinical trial we were all very excited about, but mentally, psychologically, she was not ready. And we see this all the time on the transplant floors, right? There are some patients who can be sick as a dog, right? They've got 2 lines of IV pumps on their poles, and they're still walking laps around the hall. And then there are some patients who are half as sick, and they're just lying in bed and doing nothing. And so together with Rhonda Merwin, who's a psychologist specializing in acceptance and commitment therapy, we developed a protocol of ACT to improve psychological resilience, to enhance physical activity behaviors like encouraging walking and ambulation, with the goal of improving stem cell transplant outcomes. And so we conducted 6 ACT sessions, both before and during stem cell transplant in our individuals. We conducted them as dyads, so including patients and their caregivers. And we focused on patients' beliefs, why were they going under transplant? What were they concerned about? And thinking about how they can channel those beliefs into behaviors such as being active and walking or eating healthy nutrition. And so when we looked at our control patients, as you think about it, most patients experience a decline in their 6-minute walk distance from pre-transplant to day 30. On average, we saw about a 30-40 meter decline in our control patients. Our ACT patients actually improved their 6-minute walk distance by an average of 27 meters between pre-transplant and day 30, which totally boggled my mind. The difference wasn't as significant at day 90 simply because the control patients improved, but the activate patients were able to retain those gains, which was certainly encouraging to us. In terms of other strategies, here again, I apologize, something got messed up with my slides. Here we're supposed to highlight organisms. There's been a lot of research on how the microbiome influences health and disease in a variety of ways, everything from Alzheimer's to zygomycosis. And if you look at stem cell transplant, there's a significant impact of the microbiome on things like infections, graft-versus-host disease, relapse, and overall survival. We've done work contributing to this, showing that this is universal, whether it's Memorial Sloan Kettering, Duke, University of Regensburg in Germany, or University of Hokkaido in Japan. All our patients experience declines in their intestinal diversity, and if patients with lower bacterial diversity have worse overall survival. And so we are doing a study of galacto-oligosaccharides, which is a prebiotic. It's a dietary fiber that has the potential to modulate the microbiome. And we showed in preclinical studies in mice that galacto-oligosaccharides was able to increase the production of butyrate in the gut, which is a short-chain fatty acid, a bacterial metabolite that's an important regulator, important differentiator of regulatory T cells, as well as a colonic energy source for colonic epithelial cells. We conducted a phase 1 trial of GOS, and now a randomized phase 2 trial is ongoing. But as we showed in our mice, with decreased graft versus host disease and improved survival, we're hoping to find the same thing in our patients. And so finally, I want to bring it home. I use the image of a black bag for almost all my talks because it's close to home. It's my father's black bag. He was a solo private practice general surgeon, and he used to make house calls on his patients. He'd actually pick me up from school and then take me with him, and I would have, graham crackers and apple juice in the kitchen. Probably not really HIPAA compliant these days, but this was 30 years ago. But I think it really brings to home what matters to our patients, right? And it's not just enough to care for their disease and to treat their cancer, but to really understand their life. And that's what that intimacy, being in the patient's home, taught me, is thinking about their function, thinking about their quality of life, thinking about what matters to them. Ultimately, everything we do is about our patients, looking at patient-reported outcomes, looking at their quality of life and function. Yes, biomarkers are important, right? I'm a microbiome scientist. That's one of my research passions. We have a lot of opportunity to use mobile health devices to improve care. We can look at things like resilience and accelerated aging in our patients, but our ultimate goal is really to improve pre, peri, and post-transplant care to improve patient outcomes. Thank you very much.
Great presentation. I did have a question about the high-intensity workout program. Now, you mentioned the patients could choose whatever type of workout based on what they feel like they could do. If a patient says, "Well, I don't know what I'm supposed to do," is there any type of guidelines or basic information that you would give the patient to kind of have something to do for that 30 minutes?
Yeah, absolutely. So that actually comes in during that one in-person session that I mentioned at the beginning. So the purpose is twofold. One is we do the baseline cardiopulmonary exercise testing to personalize their exercise prescription and find, those 80 to 90% heart rate reserve. But the second part is to meet with our exercise physiologist and work on a program, whether it's walking, stairs, trying a bike, figuring out what works for them. And then when the patient goes home, the first session is actually done via video conference. If they don't have a device, we actually provide them with an iPhone, so we can FaceTime with them and do that first exercise session together. And then we'll continue to follow up on them and coach them afterwards.
Awesome, that's fantastic. Thanks.
All right. Thank you guys very much.